Hi, today's lecture is about the mathematical modeling of epidemic diseases with a case study of the COVID-19 coronavirus. I am Reza SAMENI, Associate Professor of Biomedical Engineering from Shiraz University, and currently a visiting researcher at GIPSA-lab, Grenoble, France. The lecture is organized in two parts. In the first part that will be presented today, we will have an introduction to mathematical modeling of epidemic diseases. The lecture is organized in three parts. In the first part, we will have an introduction to biological systems modeling. And then we will present two of the most common modeling methods for modeling epidemics and pandemics. Let's start with an introduction to modeling. What is a model? A model is an entity which resembles a system or object in certain aspects, but is easier to work with. For instance, a model can be a set of mathematical equations. It can be a computer program, which is used for modeling a system. We usually use modeling for one of these items. The first is to identify a system. The second is to simulate its behavior. If we can identify a system and simulate its behavior, then we can predict its trends and future patterns. And we would ultimately like to be able to control the system. But we know that in the real world, it is not always possible to control the system. So the objectives of modeling get more and more complicated and hard as we move from item 1 to item 4. We are already familiar with the idea of modeling in different fields of science and engineering. We have used models for physical systems, for engineering systems in electronics, in mechanics. But the question is whether we can use mathematical models for complex biological and social phenomena such as a global pandemic. The answer is yes, but we need to guarantee a few conditions. First of all, we need to define the scope and level of abstraction of the model. A model is always a simplification of a real world system. So we are simplifying it pretty much from various aspects. For instance, we might model a social event or a biological event by a set of first order or second order differential equations, which is of course very, very simplified as compared to a real system. So we need to clarify the aspect of the system that we are modeling and the scope that that model holds for the system. For instance, some models are macro level models. They only have a reasonable meaning, or they only make sense when we have a population of, say, 1 million individuals. But some other models are micro level, and they can be applied to as few as a single individual. So these are critical factors to be clarified for any model. The second condition is that we need to know the sources of error, either in the modeling or in the data that we are observing. And it is important to know that no model is perfect. We don't need perfect models. but we need to know the sources of error, either the sources of modeling error or the sources of measurement and observation error. And of course, we need reliable data to be able to train our model and fit it over real data. Various fields of science and engineering are interested in mathematical modeling of epidemics and pandemics. For instance, mathematical epidemiology, biological systems modeling, applied mathematics, computer simulation, and control engineering. These are the different fields which are working on the modeling aspects of epidemics and pandemics. In the literature, we usually see the two mainstream modeling approaches. One of them is a top-down approach or a macro-level model. Compartmental models and spatial temporal compartmental models are the two major approaches which are commonly used in this context. In this approach, we usually use ordinary differential equations, ODEs, and partial differential equations, dynamic systems, and mathematical tools and signal processing tools such as estimation theory. The second approach is a bottom-up approach or micro-level models, in which we start by modeling the activity of the individuals inside a population. The tools that we use in this context are usually agent-based methods and cellular automata and computerized simulations. Of course, in order to have a complete method and a method which can be well fitted over data, over real data, it is ideal to be able to combine these two into a hybrid model in order to use them beside one another. Okay, let's move to the first approach, which was the compartmental model. By definition, a compartmental model is a weighted directed graph representation of a linear or non-linear dynamic system. The steps that we take for forming a compartmental model is to, first of all, we partition the population into groups of homogeneous individuals known as compartments. For instance, we might split the population in two groups of people who are healthy and people who are infected by a disease. So in this example, each of the healthy and infected group are considered one compartment. And inside each compartment, we assume that the population is homogeneous. For instance, when we consider that the population is split into healthy and infected groups, we don't discriminate between the healthy people, whether they are young or old, whether they are male or female. So we clearly see the level of abstraction that is used in compartmental modeling. Next, we need to assign variables to each of the compartments, and then we start writing equations to indicate the flow of population between the compartments. And after forming the model, we can analyze, simulate, estimate its parameters, and predict its future behavior. Let's start with an example. Suppose we want to model an epidemic. We can split the population, a population of n individuals, into 5 groups of people. The first group is the group of susceptibles, which we represent the fraction by S of t. Susceptibles are the healthy people which are potentially, which can get infected. The second group is the exposed people. They are infected peoples, but without any symptoms. They can transmit the disease, the virus, but they do not have any symptoms. So we represent the fraction of the population which are exposed by E of T. The second compartment is the infected group. These are the people who are infected and they do have symptoms. They are represented by I of T. We have the group of recovered, which are people who have been infected or exposed, but they have recovered from the disease. And finally, we have the group of people who pass away or the deceased. Since we assume that each of these five variables, temporal variables, are a fraction of the population, we can assume that the summation of all of them at each time instance is equal to 1, which builds the total population. Okay, there are various ways that we can relate these 5 groups together. What we will see in the following is a model which is called SEIR, which is a susceptible, exposed, infected, recovered model, which is a very common model in mathematical epidemiology. We consider the case of mortal and non-immunizing diseases, for example, just like the COVID-19 virus. In order to build the model, I will show each of these groups with a variable, S, E, I, R, and P. And we want to visually relate these groups together. Okay, let's see what happens when group of susceptible peoples, the healthy ones, get in touch with either an exposed or infected person. We can assume that as people meet each other, since we are dealing with a contagious disease, the people who are susceptible to the illness will gradually move from the group of susceptibles to the group of exposed. And the rate at which they exit the group of susceptibles and enter the group of exposed is proportional to the number of exposed people in the population, and also the number of infected people. So somebody who is not yet infected with the disease, the more they have the chance of meeting exposed and infected people, the more probable it is that they get ill. So this edge of the graph somehow shows the rate of exiting group of susceptibles and entering the group of exposed. We can see that the more the number of exposed and infected people are, the more the rate is between the susceptible and exposed groups. Okay, now when we have people who are exposed to the illness, they either recover with a constant rate. As you can see, the rate of recovery has been considered to be a constant factor, which is not related to any of the populations. It's just a matter of time for people who have been exposed to recover. They might either recover or they might become infected. And whether they directly recover or they become an infected person with symptoms depends on the type of the disease and the illness that we are studying. When somebody is infected, again, they either recover at a constant rate of beta, or they might pass away with a factor of mu. And eventually, people who have recovered from a disease, they might eventually go back to the susceptible group and again become vulnerable to exposure and infection. So for example, for the COVID-19, we still don't know much about this gamma factor, which defines the rate of recovered people getting back to the initial group and becoming vulnerable to the disease. Okay, if we put together all of these elements, we have this model on the left, and on the right, we have the nonlinear dynamic system, which is the equivalent of this graphical representation on the left. We can check how this model has been written. As you can see, we are writing a set of first order dynamic equations. On the left side, we always have the first order derivatives. And for each row of these equations, we are actually writing the net rates entering each of the nodes of the graph. So on the left, for example, here we have S dot equals minus alpha multiplied by S, which is the node that we are studying, multiplied by the rate of exit from that group. So we have alpha E multiplied by E, which is this factor and this factor, multiplied by the origin of the edge. The minus sign represents exit from the group. We have a similar term for this part of the model, alpha I multiplied by I. Again, it is exiting the group of susceptibles, plus gamma multiplied by R, which is this edge of the graph, which is exiting the recovered group and re-entering the susceptibles. You can see that we are writing the same set of equations, similar equations for all of the compartments of the model. Something interesting that we see here is that the sum of all of these compartments are equal to 0. Whatever term we have with a negative sign, we have the positive sign entering another compartment. We can explain it as the model is closed. A closed compartmental model is a model that does not have any external inputs or outputs. For instance, in this model, we have not considered any birth rates or any natural deaths other than the death due to the illness. Having a set of nonlinear dynamic equations, we can start with a vector of initial conditions and then numerically solve this equation to find the trend of each of the variables of the model. For instance, here you can see a simulation of what we get with a set of parameters that I've further explained in the paper that I introduced at the end of the talk. In this example, I've assumed that gamma is equal to 0. Gamma was the rate of exit from the recovery to the susceptible group. So by assuming gamma equals 0, we are assuming that the illness is sort of immunizing, and whoever recovers from the illness will no longer be susceptible. So as you can see, at the beginning, 100% of the population is susceptible. With a small outbreak, it can be as few as one individual in the entire population. The model starts to distance from its initial condition, and the number of exposed and the number of infected people starts to increase. And after a while, the population of the infected and exposed people approaches zero, and people are either recovered or a fraction which have passed away. So this is a sort of typical behavior that we see in these families of models, either SIR models or SEIR models. And what is important is to be able to predict these maximum points or to change the parameters of the model so that we would not have a big death toll, or we could control the maximum fraction of the population which are infected or exposed at each time. So these are the sort of things that we are looking for and trying to control by applying social distancing and quarantine and lockdowns. The effects are in changing the pattern of the population of each of these compartments. Okay, what can we learn from this sort of macro level modeling? Is it just a toy problem that we are solving, or are there any practical lessons that we can learn from it? The first thing that we can learn from these sort of macro level models is whether or not the model is observable or identifiable. These two are technical terms in system engineering and control engineering. By observability, we mean that if we look at the output of the system, for instance, if we start counting the number of people who are becoming infected and exposed, recovered, or pass away, is it possible to estimate the number of people who are, for instance, exposed at each instant of time? Or when we have corrupted data or inaccurate data for any reason, is it possible to estimate the true values of the variables of the compartments or not? So the good point about this sort of mathematical modeling is that in macro level models, we are able to judge about the observability of the model, assuming that the model is already accepted and we feel good about the model itself. I'll explain that later. The second question is whether or not the parameters of the model are identifiable. As we saw, we have a set of parameters that define the rate of exit from one compartment and entering in another compartment. So it is very important to be able to estimate these parameters by model fitting over real data. Another question which can be answered with these sort of macro level models is whether or not the situation is stable. By stable, we mean that, for instance, if we are able to control the spread of the disease, is there any chance of a secondary outbreak or a second or third wave of spread of the disease or not? So a good point about this approach to modeling is that we can mathematically prove the stability or instability of the situation. We can also predict the future trends. We can estimate the population of people who will be exposed or infected in a week or in a month with a certain confidence interval. Of course, nothing is fully predictable when we are talking about future. For instance, if we are talking about, say, weather forecasting, the accuracy of predicting the weather of tomorrow is much more than the accuracy of predicting the weather of, say, 1 week or 10 days. So in the context of epidemic diseases, we have exactly the same limitations. The longer the prediction time is, the less confident we are in our estimations. We can also estimate the peak of the infected population. For instance, in the case of the COVID-19, it is very critical to be able to predict the number of people who will be infected at a certain point in the future, because it is critical not to reach the break point of the healthcare system for any country, because we know that beyond that point, the mortality rate of the disease will increase and many people will die just because we do not have sufficient resources for hospitalizing people at the same time. Another lesson that we can learn from this sort of modeling is the effect of quarantine, social distancing, lockdown, and reopening, and whether they are effective in decreasing the peak of infection, or they can decrease the number of people who will pass away. And we can also predict future outbreaks, for instance, in a few months or next year, whether or not we will have an outbreak. These are one of the items that we can do with these sort of models. And finally, the accuracy of the model and the consistency of reported data may also be validated using this approach. Okay, let's move to some simulated examples. In the first example, we are considering the non-immunizing case of the model that I just showed you. In this case, we have assumed that gamma is not 0, which means that people go back from the recovered group to the group of susceptibles. As we can see on the left, if we run the simulation on a basis of 150 days, 5 months, we will see that people who were susceptible gradually decrease, but they don't exactly get 0, because as you can see, there are, after a small minimum that we have, the population of susceptibles is again increasing. The reason is that people who were recovered are gradually getting back to the susceptible group. If we extend the simulation period to, say, something like 10 years, 4,000 days, we can see that even in this simulation, we have repeated peaks of infected and exposed people. Of course, the period of repetition depends on the parameters that we select for the model. But even with this simple model, we can observe that multiple waves of infection can happen in time. This is not just something observed by simulation. It's already happened in the Spanish flu, the well-known Spanish flu in 1918. which is well known to have 3 waves of epidemics that's repeated in a period of time. The second case study is to study the effect of insufficient lockdown periods. I1 and E1, they represent the number of or fraction of people infected and exposed without any lockdown. And I2 and E2 are the fraction of the population who get infected and exposed if we apply a period of lockdown between day 30 and day 60. So we have assumed that we have a 1 month quarantine, which has started from the which has started 1 month after the outbreak of the epidemic and lasted for 1 month. We want to see what will happen if we impose such a lockdown to the population. As we can see, what happens is that the peak of the infected and exposed people is delayed. It is shifted to a later time, and the amplitude is decreased. So the good point is that we can see that a smaller fraction of people are infected at a certain time. But if we look at it in the long term, for instance, after 5 months, it has no effect on the number of total people, on the total number of people who have passed away. The reason is that after 60 days, there is still a fraction of the population who is exposed and infected. And as soon as we remove we lift the lockdown and people go back to their ordinary life and social activities, we will have the second outbreak, and the overall death toll will be exactly the same after about 5 months. The next scenario is to study the saturation or breakdown of the healthcare system. Suppose that we have a saturation point beyond which the system can no longer support any infected cases. In this simulation, I've considered, say, about 10% of the population. Of course, it's too much, but it's good for illustration. If the population of the infected passes 10% of the total population, I've assumed that the healthcare system will break down and will no longer be able to support new infections. You can see the details in the paper, but this model has been modeled with a time variant parameter, which sort of saturates as the infection rate reaches this threshold. What we can see is that on the left figures, the blue lines correspond to the case where we don't have any saturation, and the red lines are the number of infected, recovered, and the death toll when the system saturates at 10%. So what we can see here is that the number of people who will pass away due to saturation can be several times more than the case that the system had not saturated. So even if we pass the saturation threshold by a small fraction, here it's about 2.5%, we can see that the overall number of people who die has been multiplied by a factor of 3 or 4. Okay. A question that we can ask at this point is whether these models are unique. The answer is no, actually. We can have many, many models. I will just show you one example of an extension of the SEIR model that we just saw. This is actually a very practical case. The idea is that when there are people who are exposed and they get recovered, we don't necessarily know how many people were exposed because we don't carry tests on all of the population. So perhaps it's better to separate and split the group of recovered people into 2 groups. One for the exposed people who get recovered, which we represent by RE, and the other with RI, which is the group of people who became infected and then recovered. So as you can see, the difference between this model and the first SEIR model is that in the first model, RE and RI were the same group. But here we have split them so that we can count the number of people who have recovered due to infection. But we can assume that RE is not directly measurable or observable. This is just one example on how we can make this model become more and more complex. We can consider other factors. For instance, we can consider age groups, we can consider gender, we can consider seasons and time. We can consider geopolitical factors, such as the hemisphere. We already know that, for instance, in the northern hemisphere, we are in spring, that in this southern hemisphere, people are in the beginning of fall. So with such changes, we know that the behavior of the virus and its propagation pattern may change. We can talk about cities, countries, continents, the resources that exist in certain cities and countries. So the model can be made more complex in various aspects. Specifically, the problem of age group is very important, especially if we can consider the age pyramid of different countries. It will make the model a little bit more complex, but it would be much more useful for analyzing the people who are at danger in different countries. We talked about what we can do with macro level modeling, but there are surely some things which we cannot learn from this approach to modeling a pandemic or epidemic disease. The first is that we cannot model the individual behaviors. We don't get any information regarding family level or community level behavior. We just get overall patterns about what will happen to the entire society, but we won't get any information on individuals and how they should personally act. People who have background illnesses, people who have problems in their immune system, we won't be able to discriminate them unless if we consider them as a separate compartment, as I just mentioned. But otherwise, there is no way to model individual background diseases of people. So due to these limitations, we move to the second approach for modeling epidemics and pandemics, which we call the agent-based approach. In this approach, the population is modeled at the individual level. Each individual is simplified, as we called it, level of abstraction. Each individual is simplified and modeled from certain aspects. For instance, what is important about an individual in a society to be able to model it as part of the epidemic disease propagation system is that individuals can move in the society, they can interact with one another. Each individual has certain properties. They are at certain age. They have different genders. They belong to different countries. Not that the country itself is important by itself, but from this aspect that different countries have different healthcare resources. Depending on the pattern of activities and interactions in society, a person can become infected, or let's say the chance of infection can increase or decrease over time. An individual may have a background illness, may belong to different social groups. For instance, people working in dense environments, or people who move with public transport, they might be more susceptible as compared to people who have less interaction in the society. Okay, having defined this set of properties, I've just brought a few examples here, but we can make the model as complex as we want. Based on the properties that we define for each individual, the individuals start to behave and move around in a simulated environment. For instance, they might go to work, they might go to school, they might go to university, shake hands, travel with public transport, they might go to the market. These are the sort of environments that people interact with one another. Having defined the properties and behaviors and the environment for interaction between the individuals, we simulate the individuals in a simulated environment, usually a software platform, and the population starts moving around and interacting with one another based on the behaviors that we have defined for them. And their chance of getting infected increases or decreases as they interact with exposed and infected people. So what is common between this approach of modeling and the previous approach is that, again, we start with a seed of exposed or infected people. And after several steps of simulation, we monitor the population and see how their infection and health status has changed. When we have the status of infection of each individual of the society, we can calculate the marginal statistics by counting the number of people who are exposed, infected, or recovered over time. And we will end up with quite similar simulated results, just like the ones that I showed you in the macro level models. Just to give you an idea of what the modeling environment looks like, for instance, it can be a software environment in which each individual, the individuals are modeled as, say, a class, and we will instantiate objects from this class, and they can move around, they can interact with one another inside the environment. And we run these simulations just like in a cellular automata environment to see how they interact with one another. There's a very good tutorial on this sort of approach to modeling. You can follow the link here, where they have used the idea of having people who are exposed to the illness, people who are infected and susceptible, and they interact with one another in the society under different conditions. It's a very interesting video, which I recommend you to see and compare with the macro level modeling that I just presented in the first part of the talk. What are the advantages of this second approach? The good point about micro level modeling is that it provides low level and high resolution information about the individuals in a society. For instance, we can figure out what each person should do, what people can do in their families, in community levels, in certain jobs or at school. So we can get more guidelines for individuals, families, syndicates, and groups of people who are interacting in the society. Another good point about it is that it's graphical, so it might be more convincing for decision makers as compared to just working with differential equations. But at the same time, it has some limitations. The negative aspects of this approach to modeling is that selecting and tuning of the individual parameters is more difficult than in macro level models. In macro level models, we usually use estimation theory and, for instance, nonlinear least squares methods for fitting the model parameters onto the data. But it's quite intuitive to set the parameters in micro level models. Another limitation is that we don't have the mathematical proofs such as identifiability, stability, observability, and confidence intervals that we already had in the first approach. Of course, we can run multiple simulations in a Monte Carlo simulation manner and see whether we can find any confidence intervals for the group of population that we are studying. But we don't have the mathematical proofs that we can obtain from the first method. And the last limitation is that the simulations can be very susceptible to initial conditions, which we call the simulation seeds. And it happens that if you just change the initial seed, you will end up with very different results in different runs of the algorithm. Okay, I'm done with the first part of the talk today. I'll just introduce a few resources and references for further reading. You can find the theory of what I've been doing on mathematical modeling of epidemic diseases in this archive paper. I will share the source codes of the simulations on GitHub. You can have access to real-time data gathered by Johns Hopkins University, which are accessible on GitHub and also on worldmeters.info. I've also introduced a few papers and references, especially these 6th and 7th reference are very interesting videos to watch. Thank you very much for your attention.